the and has she had an ultrasound previously? And if she had an ultrasound, that might show that the placenta is in the upper part, and you don't need a repeat ultrasound. Then other causes of bleeding that you will look out or you will ask about, and then you perform, in addition to general physical examination, the abdominal examination. You determine the height of the fundus, the size of the uterus, the lie of the fetus, the consistency of the uterus, and also sometimes not necessarily at around 29-30 weeks, but usually close to term, the presentation and the position of the head, if it is the pelvic presentation, that does indicate to great extent whether there is a placenta in the lower segment or not. Now, if she has painless bleeding, then it is not likely to be associated with abruption. So that's important. So from history, you start making a diagnosis whether she is likely to have an abruption or a placenta bleeding. So that is the importance of history. And then touching the patient, taking her pulse, blood pressure, and abdominal examination, determining the position, consistency, etc. of the fetus. So you have a fair idea of that. Now, in that particular patient, we observed her. She had bleeding. We had her ultrasound, and placenta was in the upper segment. It was frontal, in the frontal area. There were no signs or no features of any uterine hemorrhage. There was no hematoma. There was no trickle of blood in the cervix. She had had cerclage. So she didn't have. So we waited for 1 day, and then the pads were observed, and they were kind of stained with fluid. In addition to blood, it was fluid, thin fluid. So leaking is the first thing. But when you do the abdominal examination, the height of fundus corresponded with period gestation, and on palpation there seemed to be adequate liquor. But to confirm that, we did ultrasound. On ultrasound, the amount of amniotic fluid was normal, so there was no leaking. So why was there that fluid in the blood or on the pad? Yeah. Now that is when we thought of doing a speculum examination. And when we did speculum examination, we saw that the cervix was rather angry looking, was raw, was irregular, and it was kind of exuberant. Not like a malignant cervix, but it was exuberant, it was raw, and in all probability, the bleeding was coming from the cervix. And what was that fluid that was on the bags? Yeah, I told you when the blood gets clotted and it is still in the vaginal canal, it obviously releases serum. The clotted blood, when it starts lysing, then the solid components, they get together and the fluid comes out. So that was welcome. Thank you. That is it. So this is the importance of history and examination, and we haven't as yet actually, since we have ultrasound and ultrasound has now become the hands and eyes of the obstetrician and gynecologists. That's why we resort to, and if it's available, obviously, it makes your life easier, and you can rule out or confirm quite a few things by 1 minute each sound. So, but the point that I was trying to make is that it is important that you take a proper relevant history of the patient, number one, and you carry out a systematic examination. Systematic, starting with general physical examination, and then even the systemic examination. I said systematic is one. Systematic is which is methodical, which starts with a certain point and ends at a certain point. That is systematic and methodical examination. But a systemic examination is different, in which you, of course, you examine the cardiovascular system, respiratory system, etc. And then you go on to the local examination. So this is how you can are less likely to make mistake, or you are more likely to get to the proper diagnosis. And then, of course, on that would depend the management. ये आज है the importance of history और मैंने अब ये किया हुआ है कि एक रेजिडेंट को कहा कि 10 मिनट में उन्होंने हिस्ट्री के पॉइंट बताने and then we'll dive on that. ठीक है, so from here we go on to Vishal's history and then नहीं हम विशाल
So the topic of my presentation is obstetric history and examination. We'll start with the history. First of all, one must always greet the patient and introduce yourself. Make sure the patient is seated comfortably. And at a booking visit, the history must be thorough and meticulously recorded. We'll start with the demographic details, in which we ask for the name, age, education, and occupation of the patient, the husband's name, age, and occupation, duration of the marriage, consanguinity.
You will ask about husband's name even before you ask the marital status. Why do you take it for granted that she's married, and why are you only taking obstetrical history? So are you taking obstetrical history? If you are, then you could say that it's obstetrical history. Because it can be a gynecological history, and the patient can be a 13-year-old girl.
Yes. In obstetrical history, I'll ask about the husband's name, age, and occupation, the duration of the marriage, consanguinity, patient's blood group, if it's negative, the husband's blood group, and the address. Presenting complaint.
I normally tell the students that when they are presenting a history, for exam, तो इस demographic detail के अंदर LMP भी यही बता देनी चाहिए और gravida parity भी यही ऐड करनी चाहिए. उससे ये होता है कि जब आप खत्म करते हैं उसकी जो basically presenting complaint तक आप आते हैं, तो जो examiner होता है they have an idea over the whole pictures. So मैं normally अपने students को ये advise करती हूँ कि इसमें ऐड कर दो. By strict sense of demographic detail, what you have said is right. इसमें सिर्फ duration of marriage ऊपर जानी चाहिए और husband's name नीचे आना चाहिए, otherwise this is all right. But from the point of view of examination, where the examiner's attention most often stays only till the presenting complaint. Over there, if you have mentioned the gravida parity and the LMP over here, it makes some sense. And if there's any chronic disease.
Presenting complaint outlines the reason why the patient is seeking healthcare. It should be precise and in the patient's own words. The history of presenting complaint is a chronological description of the development of patient's present illness. You always start with an open-ended question and ask for relative associated symptoms.
Since you are presenting obstetrical, so that is not illness. So present chronological description of the present pregnancy. So present pregnancy, history of present pregnancy. उसमें इस तरह से because almost half or more than half of our so-called patients are pregnant women who are not ill or sick, and therefore we would say history of presenting features, not complaints, right? So presenting features and history of presenting features, history of presenting features. I would not say complaints. So in obstetrics and gynecology, it has to be a little different.
Here, if we talk about the history of the presenting complaints, if the patient has any, then we can go by this old card in which there's onset, location, duration, characteristic, alleviating and
Pain
aggravating
तो
factors.
आप obstetrics पे तो pain की बात नहीं कर रहे हो ना?
Sir,
ये pain की बात कर रहे हो?
in case a patient presents with a specific complaint like lower abdominal pain or
नहीं, अभी आप specific complaints की तरफ नहीं जा रहे. अभी आप वैसे बता रहे हो कि history में क्या कुछ है. ठीक.
if you
क्योंकि वो जो slide आपकी है वो यहाँ fit नहीं obstetrical. Woman who's coming for a booking examination. So seated या lying down, वो भी उसमें भी वो थोड़ा सा है. And an obstetrical patient.
This one would fit with the pregnant patient. Obstetric history, we'll ask about the last menstrual period, We calculate the
This is
gestation.
not obstetrical history. Last menstrual period, gestational amenorrhea, expected date of delivery. The part of that is, but this is essentially menstrual history. तो चलो अभी आप जल्दी से इसको करो obstetrical history.
Last menstrual period, the gestational amenorrhea, expected date of delivery, gravidity, parity abortion, last born child, last miscarriage, and allied issues of the patient. History of the present pregnancy, in which we'll start with the first trimester. We'll start whether the pregnancy was planned or unplanned, whether it was spontaneously conceived via ovulation induction or other artificial reproductive techniques, whether the patient was taking
आप देखो ना
allocation.
history of present pregnancy आप बोल रहे हो और इसमें लिखा हुआ है history of previous labor and any complications.
So, for the present pregnancy, I'll take trimester-wise history and then ask about any.
No. पर heading आपका present pregnancy है. ये that's why ये एक है component जो history का वो है menstrual history. दूसरा component है obstetrical history. Obstetrical history में आप जो होता है वो है if there are previous pregnancies वो है उसमें वो first trimester second trimester ये present pregnancy का है. So ये आपका नहीं है. ये कहाँ से पढ़ा तुमने?
10 teachers.
10 टीचर में से पढ़ी मतलब मैंने कुछ चैप्टर्स पढ़े कभी आज से कुछ 7 साल पहले मुझे तो उसकी समझ ही नहीं आ रही थी. मैं कह रहा हूँ मुझे नहीं समझ आ रही मुझे नहीं समझ आ रही तो ये स्टूडेंट्स को क्या समझ आती होगी. नहीं इंडियंस नहीं है वो ब्रिटिश है सारा कुछ वो उस मैं तो हैरान रह गया. इट इज सच अ डिसअपॉइंटमेंट. अब देखो ना ये है अब ये इसने 10 टीचर से पढ़ा हुआ. So what is about history of previous labor and any complications encountered?
Mom's calling their mom.
अच्छा वो right. Okay.
अच्छा ना बच्चे वाले भी पढ़े.
हाँ सही है. Good.
No
No problem. चलो.
Then if we come to the menstrual history, sir, उसके उन्होंने separate किया हुआ था.
तुम रहने दो एक मिनट मुझे जरा थोड़ा देखो आज
Examination में मैम की बुक से किया.
क्या तुम बात कर सकता था आपके
मुझे वो भेजा आपने.
जी सर मैंने व्हाट्सएप कर दिया. So basically when you're talking about this obstetrical history for present history. So when you're talking again तो बहुत ज़्यादा trend हो गया कि when you're talking about the present history we talk about the first and then the second and third. I don't have any problem with that. और मुझे क्या अगर आपने first and second problem discuss कर दिया अगर वो second में आप second क्या फिर जाएंगे
ये मेरा आपको पाएंगे अगर
along with that, we will try to find out whether the patient had any problems with the first pregnancy. So important things are related. So for example, आपने देखा है करने के patient को भी pregnancy में has she been initiated booking, has she been taking iron for pregnancy or not? So these are the questions which we will ask in the present. उसके बाद जब आप आते हैं clinical history के ऊपर तो आप उससे correlate करें. So let's say that आपकी patient की clinical history में कुछ clinical history would have been taken before the surgery. अगर उस clinical history में let's say उसकी recurrent unit that seems to be just simple seems to be you will think about diabetes so then you will ask different people is what they have current condition maybe then your investigation survive. And the last thing about the present history normally याद रखो कि जिस हमारे patients आते हैं they are already admitted in a hospital. So
बिल्कुल सामने आ रही है इमरान भाई।
So you have to present the history of present illness till the date that the patient has come to you. तो ये बात बड़ी इंपॉर्टेंट है कि आप जो है आप उसकी सारे ट्राइमेस्टर्स को कवर करें, उसके एंटीनेटल को कवर करें, रिस्क फैक्टर आइडेंटिफिकेशन की बात करें, हॉस्पिटल एडमिशन क्यों हुआ था और उसके बाद उसके साथ क्या हुआ, उस सारे की बात करें, कवर इट इन द प्रेजेंट हिस्ट्री. With regards to obstetrical history, I think a couple of things are very important, and the important things for obstetrical history are her present, her past number of pregnancies and the outcome of pregnancy. उसके अंदर हमारे ज़माने में एक बड़ा अच्छा obstetrical chart होता था. उस चार्ट के अंदर हम सब कुछ एंटर कर दिया करते थे. That was the summary of whatever had happened in her past pregnancy. तो बच्चे उसमें जिंदा हैं, अगर जिंदा हैं, was they breastfed, are they healthy, बच्चों को कोई genetic disease तो नहीं है. ये सारी इंफॉर्मेशन आपकी पास्ट obstetrical history की आनी चाहिए, because this will help you manage the patient in a current pregnancy. आजकल तो high risk pregnancy नहीं आती हैं. So let's say एक patient है, उसके पीछे पिछले बेबी को autism है. So what are you going to talk about to her about this current pregnancy? Would you be able to make a diagnosis of autism? Patient would like to know that. और अगर होगा तो फिर आप क्या कर सकते हैं कि मदद हो सकती है, उसकी जो काउंसलिंग बड़ी इंपॉर्टेंट हो जाती है. इसलिए आपकी हिस्ट्री के अंदर रिस्क फैक्टर आइडेंटिफिकेशन इज एन इंपॉर्टेंट थिंग. एंड ऑब्वियसली इफ यू हैव नॉट टेकन an obstetrical history beforehand, you will not be able to make sense to the present. तो प्रेजेंट हिस्ट्री की सेंस बनती तब है जब आपके पीछे से एक अच्छी obstetrical history मौजूद. अच्छी obstetrical history will lead into the present history and then help you devise a plan of management. So let's say patient की previous pregnancy थी, इस pregnancy में कुछ नहीं है, तो आपके प्लान ऑफ मैनेजमेंट में उसकी डायबिटीज की वैल्यूएशन शुड कम अप ऑन द टॉप, क्योंकि आपको पता है कि बार-बार स्टिलबर्थ हो रही है, मे बी शी वाज डायबिटिक इन दैट प्रेगनेंसी, सो यू वुड लाइक टू डू अ जीटी. नाउ यू वुड आस्क द क्वेश्चन कि जीटी तो हम 26 हफ्ते पे सबका करते हैं, तो फिर उसमें जिस पेशेंट की जो हिस्ट्री है और इस जीटी में क्या फर्क है. सो देन यू डू एन अर्लियर जीटी as soon as the nausea vomiting settles. It generally settles at around 14 to 16 weeks. That is the time to do a GTT in a patient in which the history is different. So routine screening के अलावा भी करें. जी सर.
I'll go along a traditional pattern of history, physical examination.
Yes, sir. Voice clear नहीं है.
Voice अब आनी शुरू हो गई है. Is it there? I'm staying close to the mic, and I believe that it should be okay now.
Yes, Maria.
Essentially,
Yes,
the various components of patient management are history, physical examination, which help you make a provisional diagnosis. And of course, we add to that the investigations, and then you make a plan of management. So there is history, physical examination. It requires application of theoretical knowledge. And until and unless you have, for example, if a patient comes with the period, say 7 or 8 weeks amenorrhea, and she complains of pain in the lower abdomen, if you do not know about ectopic pregnancy, then you will not suspect ectopic pregnancy. So therefore, that maximum the eye would not see what the mind doesn't know. So you have to know the theoretical aspect of the subject as well to help you make a diagnosis. And provisional diagnosis, then you carry out investigations, you make a final diagnosis as far as possible, and then you chalk out a plan of management. The components of history are these in obstetrics and gynecology. Patient's ID, that is referred to as was referred as demographic detail or whatever, presenting complaints or presenting features, history of presenting complaints or present pregnancy, and medical and surgical history. We do not have a past history as such. That past history is part of the medical history, traditional medical history. So I wouldn't say that there is a past history, because we have specific histories. Like we have personal history, family history, menstrual history, and obstetrical history. So what generally is referred to as past history is actually medical and surgical history, and therefore I would want them to be labeled as such. So these are the 8 various components of history taking in obstetrics and gynecology. The format of the history is such that presenting complaints or features in chronological order, yeah, that of course you take that. And then the history of presenting complaints or the present pregnancy, starting from LMP and on, whether it's a pregnancy plan or otherwise. So that history. Then medical and surgical history, which, as I said, was referred to as past history, family history, personal and social history. It is important, personal history. And don't really restrict it only no smoking, no pan eating, etc., but ask about uh, what's the social environment in which she lives. Is she living with in-laws, or what kind of family setup they have? It's a joint family system, or is she living with her husband only? And whether they are living together, or the husband is working in Middle East or Spain or wherever. And also the social history, what the patient's education and what was the social environment, because mental well-being, mental health is also important, and that ought to be part of our business to know about the woman. Then gynecological history is generally this, in which menstrual history forms a component, and these are the essential points that one has to ask and note down in menstrual history, which is age of menarche. If I hear anyone say menarche, then that means that the training is.
तो मैं चीजें माननी पड़ेगी, मैं
हाँ,
तुमको बाद में बता
So it is the pronunciation of this is menarche. Menstrual cycle previous, what was, if it is the same now, you can say that she has a regular menstrual cycle 7/28 or 30 days right from menarche. That's okay. So there is no previous or present. But if previously she had a regular cycle and now for the past 6 months she has a longish cycle or irregular bleeding pattern, then it will be the present cycle is irregular like that. And then loss means amount of blood lost. It is average, excessive, scanty. These are generally the three terms that are spoken. And any associated symptom, whether it is accompanied with pain, discomfort, how intense the pain is it too intense, or is there any discharge, or there is a mid-cycle discomfort, mid-cycle discharge, and then last of all, last menstrual period. And you should be very clear about it. When was the last period? So you have to specifically ask, when did your periods start? Because many a times a woman would tell you when the periods stopped. So you have to be particular about this.
I just would like to add to what Dr. Prof has said. Basically, my question to you would be, why are you interested in the gynecological history in an obstetrical case? बताओ ना कि हमारा क्या interest है, क्यों हम पूछ रहे हैं? दो बातें हैं. One, to calculate an accurate expected date of delivery, because if the cycle of the patient is prolonged or it is short, it will affect the. That is number one. And number two, you are interested in the amount of blood loss for discussing with her the contraceptive plan. So to me, these are two important issues, and the third obviously is the last one. So ये तीन important बातें हैं जिसकी वजह से gynecological history important हो जाती है even in a pregnancy. A lot of patients will say, doctors will say, gynecological history में सिर्फ LMP important है. The answer is no. It is not only the LMP. Yeah. Loss test is important. For example, you are choosing an intrauterine contraceptive device. So if there is history of heavy loss, you would advise her not to go for a night, right?
Not copper-T.
Not copper-T. Not to go for copper-T. Maybe Malina would be better. So the amount of blood loss has got and the regularity of the cycle and the duration of the cycle is important to choose the method of contraception. So this is good information and it should be booked.
And when she says the loss is excessive, again, it has to be qualified. How many pads does she use? What is the thickness of the pads? And how many days the loss remains? Because the amount of blood lost in a menstrual cycle varies from woman to woman, from cycle to cycle. And the physiological amount is between 5 milliliters and 80 milliliters. So it can be 16 times that of 5 milliliters. And I many a times repeat what I read way back in 1976. that it does not matter whether a woman bleeds for half a week, for half a day, or half an hour. So you should, if even if she's bleeding for half an hour, that would be about 5 milliliters of blood. It is just spotting, but it may be absolutely normal for her. So therefore, you have to many a times reassure a woman that her menstrual loss is okay, provided the rest of the features are normal and there is no problem with that. So the losses, the amount of loss, the significance of that has to be uh, uh, realized, number one, and also to be explained to the patient. And is equally important components of gynecological history are contraceptive history. Has she used pills, condoms, or what kind of contraception has been used? Cervical smear, has it been taken or not? And any gynecological operations, some PNC, some laparoscopy, or whatever procedures, if there have been any. So this is gynecological history. And then obstetrical history. Summary of obstetrical history would be that number of pregnancies that she has had, including the one that she presents with, if it is an obstetrical history. Parity is number of pregnancies that have been previously. Generally, parity is considered to be that pregnancy which is taken beyond 28 weeks. But it also has to be qualified by number of miscarriages. And one of the methods generally, which I follow, and it is mostly understood all over the world, is if you say 2 plus 1 would mean that there are 2 pregnancies which were beyond 28 weeks and 1 abortion. So 2 viable pregnancies and 1 abortion. And there are other methods. Some go on to even explain or give numbers of premature births and so on and so forth. But this is comparatively simple. So if it is a gravida 3, para 2 plus gravida 4, para 2 plus 1, that would mean that she has a 4th pregnancy now. Previously, she has had 2 pregnancies which were viable or which were beyond 28 weeks, traditionally speaking, and 1 was abortion. So number of live children, boys and girls, last born and last abortion. This is summary of the obstetrical history. Details of individual combined, as Rubina was referring to that chart. I'm sure that you all must have seen that chart, which is number 1. The column first is numbering 1, 2, 3, 4 serial numbers. The second is the date. Third is the duration of pregnancy, previous pregnancy, whether full term, 31 weeks, 32 weeks, or 6 weeks, and how they turn up, any complications during pregnancy, during labor, or afterwards, and then what is the gender of the baby, male, female, and what is the present status of the baby, and also it used to be include whether the baby was breastfed or not. So
Breastfed,
immunized, etc. So that is the chart, and I would ask you, our trainees here, to follow that. It is important. It is important because if you have that chart in front of you, you can just explain the summary. But for the sake of completeness, it is important because I have a patient, and I'm going to do a cesarean section on next week. She previously, in her first pregnancy, following cesarean section, she had eclampsia. So that's important to know how that pregnancy fared and what was the outcome and was there any complication or not. So it's important. And similarly, if there have been 4 pregnancies or 5 pregnancies, and 3 of them ended in abortion and 1 ended in preterm labor, and she doesn't have a live child, it's an unfortunate history. It's a bad obstetrical history. Unfortunately, she has been pregnant 4 times previously, and she doesn't have a baby. Every pregnancy is attended with potential harm, potential dangers. Because if you look at the complications of the pregnancy, they are much more than so-called complications of the contraceptive pill, as is generally considered by lay people. So if she embarks upon a pregnancy, it is emotionally very important for her. And if it's something which goes wrong with the pregnancy, either abortion or preterm birth or a stillbirth, that's a sad thing. And uh, we as obstetricians must realize generally what happens is that as obstetricians, we do not pay much attention to abortion. All right, she has had abortion, she can have another pregnancy and so on and so forth, so on and so forth. But for that particular woman, that miscarriage, even at 6 weeks or 8 weeks, is important emotionally. And that must be dealt with and treated with respect and with empathy. So your words, your demeanor, your body language should convey to the woman that you realize that it was something which was unfortunate that happened, and you have your sympathy with her for that. So that's important.
I just want to add over here this issue of parity. A lot of books have got different definitions of abortion. So यूके वाले कहेंगे कि यूएस से कहेगा 20 weeks पे हो गया, यूके कहेगा 24 पे और हम कहते हैं 28. So for your convenience, I just want to make it clear we take it 20. So when you are talking about an abortion, it is less than 20. But obviously you will find many people जो कि यूके को follow कर रहे होंगे, किसी और को कर रहे होंगे, तो आपके उनको बताना है कि हम 28 weeks पे, क्योंकि हमारे survival rate जो है वो 28 से पहले नहीं ना होने को बराबर.
So you need to realize as a postgraduate, when you qualify this, when I said viable pregnancy, I started using that because 28 weeks traditionally in our, and now it is 24 weeks, even 22 weeks, baby has been saved in Japan or somewhere. So therefore that definition is changing. That is kind of coming down the level where it would be. So it is important to say so many viable pregnancies. And for you can say that in our hospital, we treat 28 weeks as the point differentiation. And before 28 weeks, we call it abortion, and after that, we call it early labor or preterm labor, etc. All right, I'm quite fond of this. ये वो वाला मैं तुम लोगों को पहले दिखाया हुआ मैंने काफी, लेकिन वो देखो ये इसमें है, ये this is the complete history thing. It's consolidated. This is patient's ID and summary. This is the obstetrical history, menstrual history, family, medical, surgical, and presenting complaints and presenting history. This is a little further detail, and here I have put in like this, that this is the hospital name of the woman, her age, education, occupation, marital status, the date the history has been taken. This is the medical record number. Then whether if she's married, then wife of or husband's name or her father's name. If husband's name, his age, his occupation, and here comes the parity, his blood group, address, and phone number. Now, like Rubina was saying earlier on, when you say about LMB, etc., this gives you quite a lead towards her diagnosis. If she is para 4+0 and she is 35 years of age, and she's been married for say 10 years, para 4+0, then surely infertility is not her problem. So that is ruled out. And
or para 4+0 with no live issue.
Or
there is a problem.
no, there is a problem. So and then you say obstetrical history, that if she has certain parity, that when was the first pregnancy, what was the duration, and what was the outcome, normal delivery, cesarean section, where was it carried out, what was the gender of the baby, or in 2018 she had a miscarriage at 8 weeks, whether it was followed by DNC or it was medically managed, so on and so forth. So this is obstetrical history. This is about pap smear, yes, no, and whether contraception used, yes, no, what kind of contraception.
You will be surprised, contraception के लफ्ज का मतलब आप कैसे किसी चीज को करते हैं. They don't understand what is contraception.
And then medical, surgical, and personal history. Any allergies, drug allergies, some medical problem, thyroid, diabetes, hypertension, surgical, previously operation, even appendectomy would be relevant. Then you go to the family history, diabetes, hypertension, any other menstrual history, as I already said, that this K means menarche, previous, present, LMB, and from that EDD. And by the time you come here, you would know probably in 75% of cases that what is the problem. So if she doesn't, she's been married for 5 years, she's para 0+0, and her menstrual cycle is 7 by 1 to 2 months longish. So she has infertility at least, right?
Makes the history taking.
Yeah. Or if she is para 1+0 and she has been married for 10 years and that pregnancy was 6 years back, and now she has excessive bleeding and she has dysmenorrhea, and she probably would have infertility and endometriosis probably. So by the time you come here, after having gone through this part, in majority of cases, you have a diagnosis. And if everything is all right, then probably she has only vaginal discharge, right? So even then you can have, or if she's been married for 10 years and she doesn't has any child as para 0+0, but she is having excessive menstrual loss, then it could be probably a fibroid. And if her age is 35 or pushing that. So that is the kind of approach that you would have, and then that's how it helps. Generally, I say that you take history in this order, that you take the first details of here, then you take obstetrical history if she has had previously, because you asked about how many children do you have in the earlier part. Then you go to the medical surgical history, then family history, and then menstrual history. And from there you go to this. So this is how you take the history, and that helps. In examination, if you are presenting a long case, in वो उसकी तरफ हम बाद में आ जाएंगे.
अब अगर मैं थोड़ा समझा देती हूँ examination में if it is a gynecological patient take gynecological history first, and if it is an obstetrical patient take obstetrical history first. मेरा सर का थोड़ा सा difference ये है, सर ने जो अपना order बताया, I normally do the basic profile, then अगर obstetrical patient है, then obstetrical, then gynecological, then past, and then family. I do it like this. Or other patient gynecological है, I will do the basic profile, then the gynecological history, then obstetrical, then past, then family, and then the presenting.
अच्छा, ये तो है order of history taking, और ये है order of history presenting. उसमें आप पहले वाली ये summary बता देते हैं, then presenting complaints. आपने ली history उस तरह से, then presenting complaints, और फिर उसकी medical surgical history, फिर family history, फिर in gynecological patient पहले obstetrical और फिर gynecological, ताकि उसका examination उस तरह से होगा. और obstetrical history में अगर obstetrical patient है तो पहले menstrual history और फिर obstetrical history, और उसके साथ ही फिर present pregnancy से निकालते हैं. So generally this is the way, जो रुबीना ने भी कहा उसके साथ भी इस तरह से मिल जाता है. मेरा ख्याल आज हम हिस्ट्री ही रखते हैं, क्योंकि it is 8:25.
Let's ask.
नहीं, हाँ
9:22.
हाँ चलें.
Let's ask some questions if anybody wants.
हाँ जी, आप audience on chat box
Online. Anybody wants to ask? There are 4 comments. What is focus history point? ये focus history point मैं बता दूं ये क्या है? ये जो I'm not trying to belittle anybody, but ये जो है ना जो नए कोर्स कंडक्ट करवाने वाले हैं, वो जो है वो रेक्टिफिकेशन को प्रमोट कर रहे हैं. तो वो क्या करते हैं कि वो कहते हैं कि अच्छा अगर तुम्हारा BIH का मरीज होगा तो तुम्हारे हिस्ट्री पॉइंट्स ये हैं, अगर तुम्हारा कार्डियक डिजीज का होगा तो तुम्हारे हिस्ट्री पॉइंट्स ये हैं. मेरे ख्याल के मुताबिक आपको अपनी हिस्ट्री टेकिंग एबिलिटी को डेवलप करना चाहिए, एंड यू शुड नॉट बी थिंकिंग लाइक दिस के लिए मैं इस बीमारी की हिस्ट्री होगी तो ऐसे करूंगा, इसकी होगी तो ऐसे करूंगा. आपको एक जनरल ओवरव्यू पता होना चाहिए. सो आई एम नॉट अ पर्सन हु promotes these focus history points because I think it's terrible thinking. ये आपको सिर्फ रेक्टिफिकेशन बना रहे हैं, दिमाग इस्तेमाल करना इस तरह से सब बंद करते हैं.
इसमें मैं थोड़ा सा एक और, after you've taken a detailed history, when it used to be a long case presentation in the examination of FCPS, then at the end, the examiners would ask, would you give summary of the history? And in summary, you tell only the points which are absolutely relevant. You tell that I have a patient, 35 years age, married for 10 years, para 1 plus 0, 6 years ago, she had a cesarean section. And now she presents with pain, lower abdomen, exacerbated during period menstruation, and with heavy loss. That is the presentation. Only then, if you have carried out examination, you do physical examination, and then you can say on examination, the uterus appears to be fixed and retroverted, and it is fixed, and there is tenderness in the posterior and left lateral forks. That those are the essential points for that. This is the summary which is really relevant. So you go on to that. Summary कैसे बनानी है ये मैम से पूछा गया था सवाल पर सर ने पहले बता दी अगर आप
summary में if basically summary is talking about only the salient features of the history. So for example, आपकी patient है मैं कहती हूँ Mrs. NS, 33 years, gravid 2 para 1, previous one C-section for breech presentation, now at 32 weeks of pregnancy, no complications, blood pressure 110/70, pallor is negative, PA 32 weeks, cephalic, non-engaged head and cardiac activity. This would be my summary for this case. लेकिन summary के लिए आपको examination findings add करके करना चाहिए. So we will talk about the summary when we are doing the examination. So maybe next week when हम उसकी जो next examination present करेगा वो 2-3 cases की summary भी बनाएंगे. ठीक है. So we'll talk about the summary again.
Excuse me, ma'am.
जी बेटा.
मैम अभी आप अस्सलाम वालेकुम मैम मैम अभी आप फोकस हिस्ट्री पॉइंट्स तक कह रही थी कि फोकस हिस्ट्री पॉइंट्स की बजाय आपको एज अ होल पेशेंट की हिस्ट्री लेकर चलना चाहिए. मैम आप जिस तरह शॉर्ट केस में वी हैव जस्ट 10 मिनट्स तो हमारे पास हिस्ट्री के लिए हार्डली 2.5 to 3 मिनट्स होते हैं. तो 2.5 to 3 मिनट्स में हम उस पेशेंट की जो कंप्लेन है उस कंप्लेन को एलेबोरेट करें या स्टिल वी हैव टू गो इनटू द डिटेल बिकॉज पेशेंट आल्सो हैज टू आंसर. तो हमारे पास इतना टाइम ही नहीं कि हम 2.5 से ज्यादा उसे लेकर जाएं हिस्ट्री को.
Can you tell me of a scenario जो कि एग्जाम में प्रेजेंट हुआ था, मैं तुम्हें उसका सॉल्यूशन बता दूं.
मैडम जैसा एग्जामिनेशन में आया था गैप्डा 4 है पैरा 2+1 है और पेशेंट की हिस्ट्री है विद शॉर्टनेस ऑफ ब्रेथ और बस इतना ही था. और जब हमने उसका पूछा कंप्लेंट्स मेरे पास तो खैर नहीं क्योंकि मैं तो फर्स्ट टाइम अपीयर होना चाह रही हूँ लेकिन सीनियर्स ने बताया कि जब कंप्लेन पूछी तो वो कार्डियक पेशेंट थी. अब अगर कार्डियक
टाइम ड्यूरेशन फॉर दिस पेशेंट
10 minutes मैडम. जी.
Okay, let me say something. So when you've been told that the patient is pregnant and she has got breathlessness, 2 diagnoses should come to your mind immediately. One is cardiac disease and the other is anemia. And the third would be that it is because of pregnancy that she is breathless and there is no other cause. But obviously in an examination it has to be a pathology. So फिर जो बात अब आप कह रही हैं कि जी इस focus history के क्या points होंगे, जो हमने आपको एक template दिखाया, you will go according to the template, but you will quickly cover all those areas. So I would like to take a history of heart disease. I would like to take a history of obstetrical history, asking her about the number of pregnancies, interval between births, whether she's a book patient or not, and when was her last hemoglobin assessed. इसके साथ आपने उसका examination के अंदर pallor के लिए examination करना है, and you should know what are the areas where you should be looking for pallor, and you should also be able to auscultate the heart sounds. उसमें obviously we don't expect you to find out the murmur, but आपको auscultation of heart sounds and the areas of the heart आना चाहिए, and then we can go to the discussion. This is what I would do if I were you.
ओके मैम यानी कि एक प्रेजेंटिंग कंप्लेंट से रिलेटेड जितने डायग्नोसिस आपके माइंड में आते हैं आपने उन डायग्नोसिस को लेकर चलना है.
Differential आपने केस जो है based on the presenting complaint you will make a list of differential diagnosis and then you will go. Asthma का जो breathlessness होती है ना थोड़ी फर्क होती है, but you can put it in your list of differential diagnosis to exclude it. But my first 2 diagnoses would be cardiac and anemia. ठीक है?
Anemia and cardiac.
हाँ,
Thank you, ma'am.
Indian cardiac disease and third one asthma, but asthma की history बहुत different.
मैम डिफरेंशियल्स को रूल आउट करने के बाद क्या हमारे पास इतना टाइम होगा? फॉर एग्जांपल एनीमिया के फिर रिस्क फैक्टर के एनीमिया की डिटेल हिस्ट्री के, अगर एनीमिया है तो व्हाई इट इज देयर, और अगर कार्डियक है तो व्हाट टाइप ऑफ द कार्डियक?
If you are focusing your question, I think there is time. Anemia का तो सबसे पहला सबसे common cause पाकिस्तान में anemia का ये है कि patients are becoming pregnant with very short birth interval. So वो तो आप एक सेकंड में पूछ सकते हैं, आपने patient की obstetrical history interval between births पूछा, that is one reason.
Diet,
है ना?
repeated pregnancies, lack of iron intake.
फिर poor diet, lack of iron intake, and sometimes worm infestation. So these are the kind of things which you can ask quickly. In some stations, second station was linked.
थैंक यू मैम.
अस्सलाम वालेकुम मैम.
वालेकुम सलाम.
मैम फिर हम जो इसका एग्जामिनेशन करेंगे तो फिर वो उसमें हम जो है वो रेस्पिरेटरी एग्जामिनेशन स्किप करेंगे, और जो ये जो हम
जब
lymph
आप
nodes-
हार्ट को ऑस्कल्टेट करें, अगर आपने अपनी डिफरेंशियल डायग्नोसिस में एस्थमा लिखा हुआ है तो आई वुड टेक सम टाइम टू ऑस्कल्टेट the respiratory sounds as well.
Here I might add that if you develop a systematic way and method of examining a patient, general physical examination can be carried out in 2 minutes. If you practice it time and again, you start from head and you go up to toe, in which case you do see the sclera, you do see the conjunctiva, you ask the patient to put out tongue and you examine the neck. And then also you on the way you go on to palpate the lymph nodes and you can reach up to toes. That general physical examination, and that should also include taking blood pressure and pulse.
तो वो पढ़े.
Yeah,
Dr. Veena, you are looking pretty good.
happy to see you.
Thank you, Hassan.
You go on. Give it out.
चाहने वाला.
Yeah. मैंने कहा कोई लड़की है, तो लड़का है वो. अस्सलाम वालेकुम जी.
सर, सामने को
वालेकुम अस्सलाम. मुझे लड़की बना रहे थे लाल शर्ट की वजह से. वाह, थैंक
ये
यू.
रुबीना को मैसेज आ रहा था कि मैडम यू आर लुकिंग प्रीटी लिखा हुआ आ रहा था.
नहीं नहीं नहीं, एक मिनट फर्क होती बैठ.
हाँ.
मैं 2-3 बातें ये जो पीछे लड़कियां बैठी हैं या जो सुन रही हैं उनसे कहूं. बात ये है, इम्तिहान में जब आप जाते हो तो किताब तो सारी आती है, हर कोई पढ़ के जाता है, क्योंकि ये नहीं होता कि बगैर पढ़े कोई जाए. इतना महंगा इम्तिहान है, इतने पैसे आप देते हो. यू आर नॉट रिच गर्ल्स, आपकी तनख्वाह लिमिटेड है, तो वो जाते हो. किताब का इल्म जो है वो तो हर एक के पास है, लेकिन पास कौन होते हैं और फेल कौन होते हैं? पास वो होते हैं जो रुबीना जैसे एग्जामिनर को ध्यान से सुनते हैं. She is an expert examiner or has got the reputation of being good examiner. तो जब ये बोले इनका हर लफ्ज जो है वो कीमती है, उसको दोहराओ घर जाके, क्योंकि इस तरह से आपने इम्तिहान में डिस्कस करना है, प्रेजेंट करना. इन्होंने जैसे कहा शुरू में वो सांस चढ़ता है वगैरह की लास्ट पेशेंट जो प्रेजेंट की गई, इन्होंने कहा आप फौरन 2-3 डायग्नोसिस बनाओ. इन्होंने 3 का लफ्ज खत्म किया, विच इज सो इम्पोर्टेंट. अगर 8-10 उसके डायग्नोसिस बनते हैं तो आप तो फिर डायग्नोसिस पे ही रह जाएंगे और टाइम